Good morning, everybody. My name is Giorgia Battipaglia, and I work as a hematologist in Naples, Italy. And I'm an expert in transplantation, especially allogeneic hematopoietic stem cell transplantation. And tomorrow I'm going to present data from the European Bone Marrow Transplantation Society about different prophylaxis for an important complication of allogeneic stem cell transplantation, namely graft versus host disease, particularly in patients undergoing allogeneic transplantation from related donors from donor registries. And our study focused on the use of two different GVHD prophylaxis strategies, namely Antithymocyte, Globulin, and Post-Transplant Cyclophosphamide. And we focused on the use of Antithymocyte Globulin ATG in the matched unrelated donor setting. That's 100% compatible donor, non-familial donors, receiving ATG as GVHD prophylaxis strategies, compared to patients undergoing transplantation with a one antigen mismatched unrelated donor with the use of post-transplant cyclophosphamide as GVHD prophylaxis. And what we observed is that despite the presence of mismatches in the HLA system, that is one of the major drivers in the complications of transplantation, including GVHD, the use of post-transplant cyclophosphamide in mismatched unrelated donor setting allowed similar transplant outcomes compared to ATG in the 100% compatible unrelated donors, so the matched unrelated donors. And so this allows to overcome the HLA barriers and reduce the major complications of allogeneic stem cell transplantation. As people probably know, among donor registries, we may identify in nearly 76% of patients a matched unrelated donor. That is the best donor we may identify in a donor registry. But for patients that do not find an available matched unrelated donor, potential options are either haploidentical donors, that's familial donor, we can say 50% compatible, and also mismatched unrelated donors. So the possibility to improve transplant outcomes with the use of new GVHD prophylaxis strategies also allow to have similar outcomes when using donors with more HLA mismatches, thus opening the possibility in patients that do not have a matched unrelated donor to undergo transplantation with similar outcomes to those that are completely compatible. Okay, so cyclophosphamide is a drug that has an history. I mean, it has been initially used as an immunosuppressor, but also as chemotherapy. And the first publication about its use in the haploidentical setting belongs to the group of Leo Luznik in 2008, and showed in the haploidentical setting, so a setting where HLA mismatches are their maximum expression, so that the addition of post-transplant cyclophosphamide allowed a significant reduction in GVHD incidence. And so the use of post-transplant cyclophosphamide has been subsequently extended to other donor settings, including, of course, unrelated donors, showing that these strategies allow to significantly reduce GVHD, and also as in our study, either allows similar outcomes as in other better HLA matched donors, or even better outcomes compared to other GVHD prophylaxis strategies with the same HLA compatibility. For example, in the mismatched unrelated donor setting, we compare post-transplant cyclophosphamide to antithymocyte globulin, and observe that post-transplant cyclophosphamide is superior to ATG. So this strategy has really represented a major revolution in the GVHD prophylaxis of these patients. It's a cheap drug, it's easy to manage, and being an historic drug, people really easily know how to manage this drug. So GVHD is the acronym for graft versus host disease, and represents the conflict we observe between donor T lymphocytes that do not recognize the organs of the patient. So the organs represent the non-self part, and so the donor T lymphocyte aggress the organs of the patient. And we can distinguish two forms of graft versus host disease occurring after allogenic stem cell transplantation: acute graft versus host disease, that is the early graft versus host disease, and that has its major targets in the skin, gut, and liver. And we can also observe chronic GVHD that may ideally interest every organ, and it's a less common complication, we may say, but it's also a major cause of morbidity and mortality after transplantation, especially when it's in an extensive form. When people experience acute GVHD, they either have an erythema of the skin, that's to say that the skin becomes red and sometimes with itchy symptoms. And while for the gut GVHD, the major symptom is diarrhea that may become really, really important. So, of course, patients experiencing this complication, even if they were discharged after transplantation, they may need, when diarrhea is important, to be hospitalized again. And liver complication, liver GVHD, more often expresses without major clinical symptoms. So it's the biochemistry exam that allow the identification of this complication. On the other hand, for chronic GVHD, symptoms may be subtle, especially in the limited form. And so it's really important a continuous follow-up all over the years in these patients, because limited form are easily manageable. But as I previously said, sometimes this complication may develop in a more extensive form with important complication and major problems for patient survival. I hope that our research will open new strategies for GVHD prophylaxis, improving the existing strategies. Of course, we have observed major progresses in the transplantation fields all over the years that have allowed to significantly reduce the incidence of GVHD. And so, but the problem of GVHD still remains actual. So, really looking for GVHD prophylaxis strategies that are not toxic and that reduce significantly the incidence of these important complications are warranted. And so I hope that our research activity with the post-transplant cyclophosphamide compared to ATG strategies will really make it more understandable what is the best strategy for GVHD prophylaxis to use.